Hello, good day. My name is Katrina Soriano and I'll be going through the steps that we need to do in order to insert an endotracheal tube. First, we make sure that our patient has two functional IV lines that we may need in order to push medications and fluid for support of the patient. Next, we monitor the patient with the use of a cardiac monitor and a pulse oximeter. If there is still time, we pre-oxygenate the patient for 5 to 8 minutes. This will give us a bit of a buffer in case we get into trouble as we perform our intubation. While the patient is being pre-oxygenation, we can check our equipment. So we need to check that our equipment is actually accessible and is working properly. First, we check that our suction tube is connected and working. Next, we engage the blade of our laryngoscope and we check that the light will turn on. Next, we make sure that our endotracheal tube is the correct size for our patient. And then we inflate the balloon, making sure that there's no air escaping, and then we deflate it again. Next, we insert a rigid stylet into the endotracheal tube, making sure not to go past the eyelet. We bend it slightly anteriorly just before the balloon. It should look like this. Ready your bag and check the bag valve. Have a mask ready. Should we get in trouble mid-intubation, we need to bag valve mask our patient, we would have these handy. Also, have a backup oral airway for a bag valve mask. A bougie will also be handy in case we have a trouble in visualizing the vocal cords or inserting the tube. In this instance, an LMA would also be handy. We must also have an end tidal CO2 with us, and a change from yellow to purple will confirm that we are in the airway. Lastly, a McGill forceps. This will help us remove any obstruction that may be in the patient's airway. We can also lubricate the balloon portion of our endotracheal tube in case we have a patient with a dry airway. So this will make it easier as we do our intubation. Next, we position the patient. The patient's head should be on the lower part of your sternum. And then we also adjust the head of the patient so that it is in a sniffing position. We flex the head a little bit and elevate the occiput. The reason that we are doing this is so that we straighten the airway as much as possible and will make the visualization and intubation much easier. Next, we make sure that our patient is sedated. To check that our patient is properly sedated, we can check for the laxity of the jaw. Next, we remove the oxygen mask and then we leave on a nasal cannula. This will aid the patient for apneic oxygenation. We hold the laryngoscope on the left hand with the butt of the blade on the hypothenar eminence. We grasp with the 4 fingers and use the thumb on the handle for control. And then you may use the right hand to pull the cheek and to visualize the tongue. In this demonstration, I am using a Macintosh blade which is curved. Another kind of laryngoscope is the Miller blade which is straight. What we need to do is place the blade on the right side of the mouth, sweeping the blade from the right to the left going to the midline. Do not use the teeth as the fulcrum. And as we sweep the blade from the right going to the left, moving to the midline when we move upwards and forwards a little bit. Upon visualization of the epiglottis, we tuck the blade into the vallecula. This will move the epiglottis and now we'll be able to visualize the 2 vocal cords. We ask for the endotracheal tube from our assistant, making sure not to lose sight of the vocal cords. We insert the endotracheal tube coming from the right, continuing to visualize the vocal cords. And then we can use the tip of the tube or the balloon as our marker. If you decide to use the tip of the tube as your marker, we go 3 to 4 cm past the vocal cords. But if you're going to use the balloon as your marker, we go past the vocal cords 1 to 2 cm. And then we remove the blade, holding the endotracheal tube against the teeth of the patient. And then with your other hand, you remove the rigid stylet. We inflate the balloon or have an assistant. We ask an assistant to inflate the balloon. Next, we use an end tidal CO2 detector, and noticing a change in color from yellow to purple will actually confirm that the tube is in the airway. We attach the bag valve to the endotracheal tube. We give a couple of breaths using the bag valve, and we watch for the color change on our end tidal CO2 detector. And then have a nurse or you yourself or an assistant listen to the bilateral breath sounds on the axilla and in the epigastrium. This will actually confirm that we are hearing the breath sounds over the lungs and not over the stomach. Next, we secure the tube with a tape. We confirm that the tube is in the airway by performing a post-intubation X-ray. make sure that the patient is properly sedated, medicated, and in adequate pain control. Um, this is in order that we avoid having a patient waking up with a tube in his throat. So that would be all. Thank you.